Hello everyone, my name is Conklin, and today I will be presenting on diabetic neuropathy, which is a chronic complication of diabetes mellitus. Diabetic neuropathy is one of the most common and debilitating complications of diabetes and can significantly affect a patient's quality of life, mobility, and independence. During this presentation, I will discuss the patient background, pathophysiology, epidemiology, diagnostic findings, evidence-based guidelines, treatment recommendations, patient education, and follow-up care related to diabetic peripheral neuropathy. This patient is a 75-year-old Caucasian female with multiple chronic health conditions and long-standing diabetes. Older adults are at increased risk for diabetic neuropathy due to prolonged exposure to hyperglycemic and age-related vascular changes. Social determinants of health are also important to consider. Access to healthcare, transportation, financial resources, and support systems can all impact diabetes management and adherence to treatment plans. Patients with chronic illnesses often require ongoing monitoring from multiple healthcare providers, making continuity of care extremely important. This patient has a complex medical history that includes cardiovascular disease, peripheral artery disease, diabetes, hypertension, sleep apnea, anxiety, and diabetic peripheral neuropathy. Her medication regimen is extensive and reflects management of both diabetes and multiple comorbid conditions. Gabapentin is being used specifically to manage neuropathic pain symptoms. She is also taking medications for glucose control, hypertension, cardiovascular protection, and pain management. Her use of compression stockings may indicate underlying venous insufficiency or peripheral vascular concerns, which can further complicate circulation and wound healing. This patient's multiple chronic conditions place her at higher risk for falls, skin breakdown, infection, and decreased mobility. Diabetic neuropathy refers to nerve damage caused by chronic elevated blood glucose levels. The most common form is peripheral neuropathy, which primarily affects the feet and lower extremities. Symptoms can range from mild numbness and tingling to severe burning and pain and complete loss of sensation. Loss of protective sensation places patients at risk for unnoticed injuries, foot ulcers, infections, and amputations. Because diabetic neuropathy develops gradually over time, early screening and intervention are essential. The pathophysiology of diabetic neuropathy is complex and multifactorial. Chronic hyperglycemia leads to metabolic dysfunction within nerve cells. Elevated glucose levels increase oxidative stress, which damages nerves and surrounding blood vessels. Microvascular damage reduces oxygen and nutrient delivery to peripheral nerves. Advanced glycation end products, also called AGEs, accumulate in tissues and contribute to inflammation and cellular dysfunction. Neuroinflammation and abnormal nerve signaling ultimately impair nerve conduction and sensory function. Over time, these processes lead to progressive nerve degeneration and chronic pain. The primary cause of diabetic neuropathy is long-term uncontrolled hyperglycemia. Persistently elevated blood glucose damages both nerves and the small blood vessels that supply them. Additional contributing factors include oxidative stress, chronic inflammation, and reduced blood flow to peripheral tissues. Several risk factors increase the likelihood of developing diabetic neuropathy, including older age, obesity, hypertension, hyperlipidemia, a history of smoking, sedentary lifestyle, and duration of diabetes. Patients with poorly controlled diabetes over many years are especially vulnerable. Diabetic peripheral neuropathy affects approximately half of all patients with diabetes, making it one of the most common diabetic complications. The condition is more prevalent in older adults and patients with long-standing uncontrolled diabetes. Diabetic neuropathy is a major contributor to falls, foot ulcers, infections, hospitalizations, and lower extremity amputations. Loss of sensation can prevent patients from recognizing injuries, which may delay treatment and worsen outcomes. Beyond physical complications, chronic neuropathic pain can negatively affect sleep, mental health, mobility, and overall quality of life. Diagnosis of diabetic neuropathy includes both subjective symptoms and objective findings. Subjectively, patients may report burning pain, tingling, numbness, pins and needle sensations, difficulty sleeping, and balance problems. Objective findings commonly include decreased sensation on monofilament testing, reduced vibratory sensation, diminished reflexes, impaired proprioception, and gait abnormalities. Testing that can be completed is a hemoglobin A1C, which is important for evaluating long-term glycemic control. Additional testing such as nerve conduction studies and electromyography can assess nerve function and severity of damage. Laboratory testing, including a CMP and vitamin B12, may help to rule out alternative causes of neuropathy. This patient's medication regimen includes gabapentin, metformin, and semaglutide for management of diabetic neuropathy and diabetes. Gabapentin works by modulating calcium channels in the nervous system to reduce abnormal nerve signaling and neuropathic pain. Metformin decreases hepatic glucose production and improves insulin sensitivity, helping control blood glucose levels. Semaglutide, also known as Ozempic, is a GLP-1 receptor agonist that stimulates insulin secretion, slows gastric emptying, and promotes weight loss. Improving glycemic control is one of the most important interventions to slow progression of diabetic neuropathy. The American Diabetes Association standards of care emphasize routine screening and prevention strategies for diabetic neuropathy. The ADA recommends annual comprehensive foot exams for diabetic patients and routine neuropathy screening beginning at diagnosis for type 2 diabetes. The guidelines strongly emphasize glycemic control to reduce progression of neuropathy and complications. Patient education regarding foot care and fall prevention is also strongly encouraged. The American Academy of Neurology recommends evidence-based medications such as gabapentin, duloxetine, and tricyclic antidepressants for painful diabetic neuropathy. These guidelines encourage individualized treatment plans based on patient symptoms, comorbidities, and tolerance to medications. Importantly, long-term opioid use is discouraged due to limited benefit and significant safety concerns. Key recommendations for this patient focus on slowing disease progression and preventing complications. Improved glycemic control is essential and should remain a primary goal. Gabapentin therapy should be continued and optimized, while duloxetine could be considered if pain becomes uncontrolled. Daily foot inspections are extremely important because decreased sensation may prevent the patient from noticing injuries. Routine podiatry care can help to prevent ulcers and infections. Fall prevention strategies are also necessary due to impaired sensation and balance difficulties. The patient should continue regular A1C monitoring and be encouraged to follow a diabetic diet and regular exercise plan. Patient education plays a critical role in preventing complications from diabetic neuropathy. Patients should be taught to perform daily foot checks and inspect for redness, cuts, swelling, or wounds. Proper footwear is important to reduce pressure points and prevent injuries. education regarding blood glucose monitoring, and medication adherence helps improve diabetes management. Patients should report wounds or signs of infection immediately to prevent worsening complications. Smoking cessation should also be encouraged because smoking worsens vascular disease and circulation problems. Fall prevention strategies, including proper lighting, supportive footwear, and home safety modifications, should be also discussed. Ongoing follow-up is necessary for chronic disease management and prevention of complications. This patient should continue following up with primary care and endocrinology every 3 to 6 months. Annual diabetic foot exams and ophthalmology evaluations are important components of diabetic care. Referral to podiatry can help with nail care, pressure reduction, and ulcer prevention. If neuropathic pain worsens, referral to pain management may be appropriate. Physical therapy may also improve gait stability, balance, and overall mobility. In conclusion, diabetic neuropathy is a common but serious complication of diabetes that significantly impacts mobility, independence, and quality of life. Early intervention and glycemic control are essential to slowing progression and preventing complications such as ulcers and amputations. A multidisciplinary approach involving primary care, endocrinology, podiatry, nursing, and physical therapy can improve patient outcomes. Nurses play a critical role in patient education, early detection, monitoring, and chronic disease management. Through evidence-based care and patient-centered education, healthcare providers can help reduce complications and improve quality of life for patients with diabetic neuropathy. These are the references used throughout the presentation, including evidence-based resources from the CDC, Mayo Clinic, NIDDK, and peer-reviewed literature regarding diabetic neuropathy and diabetes management. Thank you for listening.